good evening, good afternoon to everyone. I'm seeing that we're slowly getting people trickling in. Great to see that you're all joining us today. In our next webinar, this is our TBPPM webinar that we're talking about caregivers, and specifically the caregivers that are not formally part of any system. So we're really excited to bring this topic to you because there's a lot to say about the people that are really involved in giving care for the people that are living with TB. So thank you, because this is great to have a chance to discuss this. So we are live streaming right now also on YouTube, and we will show you the details in the chat. You have a chat, you have Q&A. So if you have any questions for any of the presenters, please use the Q&A, because that's the easiest way for any of the panelists to respond, and it also allows the moderator to really specifically look at the questions. The session is being recorded and will be available afterwards as well for anyone who's interested. You can use subtitles for your own use, and if you feel the need to it, that's at the bottom of the Zoom link. And we will be sharing the report, recording all the presentations in the upcoming week. And you will also see some of us on social media announcing some of the information that's being shared. So with us today, we have a fantastic panel. We have a variety of people that are involved in the informal caregiving, people that do research about it, who will be talking about what data they find. We have an actual caregiver with us who is right now giving care of someone with TB. We have WHO's perspective, and we have a perspective from an organization in India who will be talking about various caregivers that are involved in their day-to-day work. So with that, I would like to welcome everyone and hand over to our fabulous moderator of the day, which is Jeremiah Chikavore. Jeremiah is joining us from Durban, all the way in South Africa. He is the founder of Shift TB, which is looking at social science involved in TB, and he is a senior research specialist at the Human Sciences Research Council in South Africa. He brings a lot of experience in research and data from multiple different perspectives, and looks at social science, qualitative methods, health access, care seeking, stigma, youth and young people, and many more. And he's the perfect person to help us moderate today's session. So Jeremiah, and by the way, all bios of our fantastic panelists are going to be available for you on the platform. I'll put the link in the chat. So if you want to read the full background on everyone, you can find it there. Jeremiah, the floor is to you to introduce the topic and our speakers. Thank you so much.
Thank you so much, Petra, and just to say greetings to our panelists and everyone who is listening in. It's a pleasure for me to be, and thank you, Petra, and all the organizers for putting this together. This is really a very important topic to engage on. So I will just quickly give my some running thoughts around this topic. And the WHO highlights that evidence confirms that social support can predict health status and mortality, and it is affected by about 4 factors: informational support, emotional support, companionship support, material support. It can promote adherence and better psychological state, and it helps the persons with tuberculosis to navigate problems related to different stages in tuberculosis treatment. At the same time, caregiving is such a complex issue, very complex. It is so many dimensions in different contexts, in different spaces. And in terms of what it touches and what determines it, it touches on notions of wellness, on bearing the responsibility of helping and accompanying the person with TB through the journey of physical and mental recovery. It is also tied to prevailing concepts of what illness is about in various settings. And the caregiver is located at the center of managing, maybe alone, maybe as a collective, maybe even as a group, that is varied understandings of what illness and restoration of health is. So the caregiver is not really a solid concept, or it is many roles, it is many emotions, sometimes many individuals all in one place. And it puts heavy demands on time, generates anxieties about the present, about the future. Sometimes we see resource depletion while trying to optimize care even with limited resources, or when the caregiver or the patient lose access to income. And we have learned over time how tuberculosis leaves families poorer during illness, but even well after the illness. And caregivers can be any age or gender. It is highly contextualized. So I'm not going to continue talking because I could go on and on. These are just some of the thoughts that ran through my head. But I'm going to hand over to our fantastic panels to engage with these issues further. And without spending much time, I will ask our first panelist, Dorothy, who is going to talk about her journey, her TB journey, and the caregiving she's currently involved in. So very briefly, Dorothy is a social activist who is a TB champion and TB survivor, a woman human rights defender and trainer of trainers. She's a member of the Network of TB Champions Kenya and coordinates the network's chapter in Bungoma County in Western Kenya. And she has been an active community TB actor for 14 years and is well recognized. So without further ado, over to you, Dorothy.
Dorothy, you need to unmute yourself.
Hi, everyone. I'm Dorothy from Kenya, in the western part of Kenya, Bungoma County. And just as I've been introduced by Jeremiah, I don't need to say much. Whatever he has said is what is it about me. I love to do TB work with a lot of passion. And today I want to talk about social protection. And when I'm talking about social protection, I want to talk about social protection in the community context. First of all, I cannot start talking about social protection in the community without talking about the basics of social protection. Social protection, we find that it is a set of policies and programs that at least they help us to design, they're designed to help reduce poverty and vulnerability through certain set programs, so that people who are affected by a certain disease are not incapacitated in protecting themselves, or maybe like they don't face hazards that are going to make them lose their incomes. So why do we talk about social protection in the community context? Social protection in the first place is a very important component towards the TB response mechanisms. Why are we talking about it as a most vital aspect in TB response? It is because when it comes to tuberculosis and poverty, there is a very thin line in the difference, because we find that most of the population that is affected by TB normally are the ones who come from the middle and the low income communities. And that is why it is really beating us hard. Who are the most vulnerable people that are mostly affected by these social protection issues? In my context, in Kenya, in Bungoma, in the western part of Kenya, it is mostly the alcoholics, the people who are living in the slums, the laborers, because these are people who are doing, either they are not working, or if they are working, they have to do something every day that is not permanent. So in any case, a day comes that they cannot go to work, then it means that day there's no income in that house. And most of the times in our setup, you find that mostly it is the men who have to go to work and fetch for their family. So if this man suddenly has to sit down, cannot go to work, and then the family cannot fend, then issues start cropping in. So when we talk about social protection, we can also not fail to talk about the social determinants of TB. And we find that the epidemic is strongly influenced by social and economic development, including health-related risks, such as undernutrition, alcohol use, substance abuse, and health system weaknesses. And when we talk about the social determinants of TB, still you will notice that we're still talking about poverty. There's an element of poverty. There's an element of overcrowding, and there's an element of poor housing. Why poor housing? Because most of these people are found in the informal settlements. Now, I want to talk about my experience as a caregiver who is voluntary, and in my journey with the social protection issues at the community level. What normally happens? How do we first map out people who really need these interventions for social protection? We start out by mapping out the vulnerables. How do we identify them? We identify these people through the household assessments during normal household visits. We look at the income and the way they stay in the households. Number two, we also identify these people through the community support groups, where most clients are open and they tend to air out the issues that are affecting them. And that is how you tend to pick on issues that each one of them is having. Then we also have through the TB clinic, or via the healthcare workers report, where we get the data or a report on the malnourished TB recipients of care who are not improving even with the nutritional supplementations. What approaches do we use? When we find such cases we have marked out, one, we go on fact-finding missions. How do we do the fact-finding missions? By establishing exactly why the client is in that condition in the first place. Number two, once we identify these people, we link the clients to programs that can assist them. For example, sometimes a recipient of TB care has been admitted because of other conditions, maybe that are affecting them because they have TB, and you find that those services, they cannot get them for free. We normally go and talk to the people who can give them waivers from the hospitals because they cannot pay. And the more they continue staying in the hospitals, the more the bills accrue. So they benefit from the waivers. We have food programs. And through the food programs, there are some that come from the community, some that come from the county, and some that come through the nutritional clinics. Then we have the social welfare programs. These are programs that sometimes they deal with whereby maybe you look at the person and then you identify with a social program that maybe identifies with such types of people. Maybe we have people who are living with disabilities, you connect them with those ones. We have people who are elderly, so you link them with the elderly support programs. And then some of the children, we also link them to the OVC, the orphans and vulnerable centers, whereby they can be assisted. We also have the medical social workers, whereby if the situations are too strict, we go to the medical social workers, who maybe later on will be sent to go and assess the conditions of these people back at home, so that maybe finally they can be assisted. Now, again, what have we been doing? We have been having food baskets from the TB champions themselves. You know, most of the TB champions are people who have gone through the TB disease experience. So what we do, sometimes you find that even if it is voluntary, but you can feel for the client, because like you've gone there, you've seen the patient, the client is on medication, and then you're asking them, why are you not taking this the way it is supposed to be taken? They're telling you, they just call us sisters. The word, another word for nurse or a healthcare worker. So they say, you see, nurse, I did not take this one because yesterday I did not have water. yesterday I did not have anything. So sometimes things like water, you've got to buy for them. It forces you at times to even buy 20 liters or 40 liters of water. Then maybe you say one is going to be used by the family, another one is going to be used by the recipient of TB care. But at times also you say, even if you have linked, you've bought the water, they will take the medicine with the water. Yes, but what are they going to eat? So these are some of the things that are really disturbing our mind. And then again, also through the TB champions and maybe through identifying well-wishers, the conditions under which most of these recipients of TB care live are very, very, very poor. You find that someone is sleeping on a mud house whereby the floor is not cemented and the floor is wet, especially for those who are living in swampy areas. So this person maybe is putting on a box down there with a very thin mattress, and then you find that again pneumonia sets in when this person is on TB medication. So sometimes you wonder why the client is coming regularly for medication, but they don't have improvement. So you find that maybe now you have to come back because these are things that are not provided for in the provisions for social protection. But now what do? I even approach the healthcare workers. I tell them this person does not have blankets, this person does not have a jacket, this person that is sleeping on a carton on the floor. Then sometimes we donate, someone comes with a blanket, someone comes with bed sheets, someone comes with what, and then we give them. But sometimes we say, even if we provide those ones, issues about food, what can we do so that maybe we find sustainable means for these clients to continue with, because you cannot be helping them every now and then from your pocket because you're also a volunteer. We have scenarios whereby some of them are living in houses that are very despicable. Maybe a house has got a lot, it is a mud house, it has a lot of holes on the sides. So if this person is having their own parcel of land, then what we normally do is we do a donation of trees, we do a donation of nails, and then we call a community people to come in solidarity so that we can put up a mud house for these people, and then they have a house that is not slanting or maybe is not having poking holes on the sides, and that one has really happened for us. Then again, we have on sustainable means, when we found out that we could not provide food for the clients every day, then we started teaching them on how to do simple farming on the small spaces that they have besides them. We have also been trying for those ones who are coming up health-wise, we encourage them to enroll for the health insurance so that whereby they're able to pay for 500 shillings just in case they have to go through a process at the hospital that is not given as a free TB service, then at least the fund can pay for them. We have been encouraging some of them to open up small businesses. And again, some of them who cannot open, especially the ones on DSTB, you find that these people, there's no any form of financial support that they get from the TB program in Kenya or maybe the government of Kenya. So what we do is at times, those ones who are really, maybe somebody is a single mother, is a single parent, and they have children staying with them, children who do not have anybody to take care of them, we feed them, we take food to them, and then what we do when they start regaining their health, we open up small businesses that we are sure at least by the end of the day, they are going to get something. So most of the times we do help them to set up food businesses, like maybe frying chips in the evening. We do vegetables and tomatoes, things like that. And what again we have been doing on social protection, because social protection also is not just about giving them money or linking them to people who can help them, but it also involves helping them to maintain, for those who have been employed, helping them to keep their jobs. And we find that sometimes when somebody has been sick with TB for the longest time, the complications are normally very, very, what can I say? The complications are severe. So when the complications are severe, you find that this is somebody who, even if they start treatment, they won't respond very fast. And then also our body mechanisms are different. There are those ones who start medication, then the ADRs hit them very strongly. So what happens if this person was employed? Every now and then they have to ask for permission to stay home. Then you find that now it reaches the time that staying at home all their time or their health condition becomes a threat to keeping their work. It forces you, once they open up, it forces you to go to the employer to ask them to give them time to recuperate and to also keep their job so that they don't have to lose their incomes. And what we normally do is to sensitize them, tell them TB can get anyone. We tell them to imagine also, what if today it was not this employee, it was them? How would they have loved to be treated? We also do this by advocating for clients to stay on sick leave that is paid, because sometimes you find that an employer will say, okay, I will keep this person at work, but now I will let them recuperate at home until they get their strength, but I will not pay. Then we also say, no, that is not viable. This person has been working for you. Well, how do you expect them to go and survive, maybe get food and other services, if you are going to keep their money, they don't get it? This is also going to affect them. Another aspect that we have been doing blood donation drives through supporting sports. And like even recently, we had to support a football club. And what kind of support came through here? We all know very well that most of our TB clients also suffer from anemia. And getting just blood donated like that is not easy. So we had to look for a strategic way, because this is also, apart from malnutrition, anemia is also killing a lot of our TB clients. So you find that the footballers, because we supported them, they agreed and said they also want to find out exactly how many people who are recipients of TB care are suffering from anemia, and they are really willing to come and donate blood for them. So this is also another exercise that has always helped us. Then another thing that we have also done in this is that we have been identifying other partners who can give free services to our people. So like we have been working in collaborations with people like KCCB, who have been giving free chest x-rays to children from above 5 years to 14 years. And we have been having Dumisha, Afia, who have been giving us mobile chest x-rays for communities, and also the National TB Program chest x-ray machines. So the moment we follow up and find out on advantages like these ones, we also show our clients where to go and get these services. We have also linked clients to the closest facilities to reduce transport cost implications. We have also approached schools to let the children of the affected parents who are recipients of TB care from being sent away from school. And then again, we are now acting as advocates on policies on health insurance that favors recipients of TB care. Now, what have we achieved? Advantages of social protection interventions. We have come to realize that we have happy recipients of TB care. We have had improved adherences. We have reduced deaths due to malnutrition. We have treatment success rate improvements. We have improved financial statuses of the recipients of TB care households. We have improved the food security through sustainable methods. So I think this is what I can talk about. Because time is also short, I just wanted to give the examples of the success stories that we had. Only if I'm given a go-ahead to talk about this, then maybe sometime later I'll talk on that one. Thank you.
Thank you so much, Dorothy. You're really doing amazing work, just doing this very practical work that is grounded in the community and solving all these different things from different perspectives. Really, really great work. Please keep the questions coming in. I will have some time to attend to the questions later on. But really, thank you so much, Dorothy. maybe we can move on to our next speaker. And we are going to listen now to Sumona. And I'll just give a very brief introduction. So Dr. Sumona Datta is a British clinician focused on infectious diseases and microbiology. She has experience in providing healthcare in India, Lesotho, and Kathmandu. And since 2012, she has been based in Lima, Peru, working on strategies to improve TB care. You can get more on illustrious CV on our website after the webinar. But over to you now, Sumona.
Thank you very much. I'll just share the screen. Can you confirm that you can see my slides?
I can see them.
Perfect. Thank you. Okay, well, thank you very much for inviting me to give this talk on a really important topic. And I'll be giving some research findings that we found here in Peru, which you can see is the country in Latin America, which is in red in that blue logo. And background photo is the communities that we help advocate for and provide research data from. So Jeremiah gave a really lovely summary of my kind of academic pursuits, but like everyone here, we have lots of other roles. I'm a healthcare provider, I'm also a mother, a daughter, a partner, a next of kin, a friend, a legal power of attorney. And like many of us, if not all of us here, I'm also and have been a caregiver. And caregivers, there's lots of evidence on caregiving, and especially in the background of geriatric medicine with dementia, mental health, in oncology, palliative care, and also in pediatrics. And from that world of evidence, which is running decades now, it's very clear that those who are caregivers for a long period of time have increased rates of early death compared to their community members who are not experiencing caregiving, have increased sleep deprivation, depression, distress, anxiety, social isolation, and extraordinary high rates of suicide. And so if we know so much about caregiving from all the experience that we have, just looking at people and also all this evidence that's been generated in these other diseases and other systems, is there any real need to then be fleshing out caregiving in TB? Is it any different from caregiving in dementia or schizophrenia or in cancer or end-of-life care? Well, for me, I think it is. Because for TB, we know that household contacts are a much higher rate of getting TB or becoming ill themselves with TB, more than community members living in the same community who don't or never have had an individual with TB in their family or in their household. TB extremely stigmatizing. So all the data I'm showing here are data from our research. So the Kaplan-Meier curve from above is no different from any other study that we know that people who are at risk and household contacts have a higher risk, especially those who share a bed. And also there was a big study in Brazil that parents of under 5-year-olds also have a higher risk of being diagnosed with TB or having co-prevalent TB. This again below is a study that we did asking about stigma and what stigma actually meant to community members that were struggling with TB. And as you can see, there's discrimination, rejection, embarrassment, fear, and that's not just isolated to the patient. The entire family is experiencing these negative connotations of stigma and TB. Also, TB is a syndemic. It doesn't just come on its own. So this is a lovely study we did about multimorbidities. 92% of people that are taking TB treatment are also struggling with other physical comorbidities, mental health morbidities, of social morbidities, and economic morbidities. So it really is a syndemic. So this issue of the minimum 6 months to maximum however long, it's not just tuberculosis. They're also facing many other comorbidities and issues that are really impacting their quality of life. And also this is a study not from me, but a policy analysis showing that, we know that TB is more common in LMICs, in low and middle income countries. yet they're the countries that have least protection for caregivers. So this is a lovely little map that I found showing which countries offered paid leave or no paid leave to adult family members who were unwell. And Peru, you can see in Latin America, is green. Looks extraordinary. But actually, when you look at the law, it's 7 days. So you're given 7 days paid leave to be able to look after a family member if they're severely unwell. So that really doesn't cut it for tuberculosis either. Okay, so I'm going to really quickly whiz through a study that we did measuring quality of life. Now, at the turn of the millennia, there was a lot of interest in how we measure quality of life, what quality of life means. So we all know that health is the complete well-being of physical, mental, and social elements, and not just the absence of disease and infirmity. So if we're talking about complete well-being, how do we measure complete well-being? And so this WHO did an amazing endeavor of 15 different collaborating centers around the world and what well-being actually meant to communities, and came up with all sorts of different domains. And it was about their position and their perspective, not somebody telling them that they had well-being or not. It was defined by people about what was important to them for their position in life. And it basically came to this questionnaire, which was about 100 questions, and slowly has been whittled down to 26 and to an 8-question screening tool that was made by the WHO Europe region, which still maintains the major 4 domains, but shortened to these 8 questions. So essentially they asked to think about your life, maybe all of us could do it, think about your life in the past 2 weeks. How would you rate your general quality of life? How satisfied are you with your health? Do you have enough energy for everyday life? How satisfied are you with your ability to perform activities of daily living? Sorry, that's what ADLs are. How satisfied are you with yourself? How satisfied are you with your personal relationships? Do you have enough money to meet your needs? Doesn't matter how much money you have, but is there enough to meet the needs that you require? And are you satisfied with your living place? And what we did was we asked that. We work in 32 communities in the state of Cayenne, Peru, which is part of Lima, the capital. And over an 18-month period, every single patient that was diagnosed with TB or starting TB treatment in those community health centres were asked to participate in this study and fill out this questionnaire if they were over 15 years old. We also invited all their household contacts. So with the 1,545 patients that were over 15, we had 3,180 contacts who were over 15, of whom 1,383 identified themselves as caregivers. Now, it was very difficult because, as Jeremiah pointed out, and Dorothy also, you don't have one primary caregiver. So on the questionnaire, it was very difficult, like who was the caregiver? Well, there wasn't a primary caregiver, it was normally as a group. So what we did is we made a surrogate marker. So if they were a parent, they were a child of an adult, of a elderly individual, or they were a spouse or a partner who were living in the same conditions, they were considered as caregivers. And when we discussed with the participants, they felt that that was an acceptable way of identifying caregiving in general, which can be a shared endeavor. And we also randomly recruited households in the same communities who were not part of the TB program, so they were considered as our controls, to actually identify whether the well-being differences we may or may not be seeing is something that is relevant to being affected by tuberculosis, or whether it's something that the entire community is actually struggling with at the same time. Just quick demographics, so we can see what our caregiving group was in comparison to the controls. They were older, they were predominantly female. They actually were less likely to have completed secondary education, so they had less kind of formal education. And actually many of them had previously had TB or were actually struggling with TB at the same time. So we had to rejiggle all these groups and not keep them as TB controlled people that were patients taking treatment, whether they were caregiving contacts or non-caregiving contacts, and change them to be called people with new diagnosis of TB, person that was a carer of TB, people that previously had TB, and people who had never had TB. And as you can see, it was one you could see the red means bad, they are dissatisfied in their scores. And the score actually goes up to a maximum of 32. So if we just look at the column on the right, the TB never group in these communities, they don't have high quality of life. Their satisfaction with their quality of life is pretty low, it's around 19. And if you have a new diagnosis of tuberculosis, you've lost about 5 to 6 points of the scale, which is quite significant when there's only 8 questions and only 5 points allocated to each question. Okay, but if you look at those who are providing care with TB caregivers at 1,341, they not only had a much higher amount of dissatisfaction and not satisfied with their quality of life, but there were actually statistically significant different scores. They were scoring lower. So if I was interested to find out in which domains were they scoring lower. And if you can see, this is quite an abstract spider plot, but this is all the questions, 8 questions in like a spider plot. The further out you go, the more satisfied they are. The more into the center you are, the less satisfied, the more dissatisfied people were with those certain domains. The black solid line is the community controls, people who never had TB, the TB never group. The black dotted line are people who are with a new diagnosis of TB. And the red dotted line is the TB carers. So as you can see, the TB carers said that they had similar health, similar energy, similar ability for their activities of daily living, similar satisfaction with their relationships as people who'd never had TB, but they were more dissatisfied with money, with their financial needs. They were more dissatisfied with their general quality of life. So although those other domains didn't really capture what it feels like to be a caregiver or the impacts of quality of life by proxy, people were generally dissatisfied with their general quality of life and general stress and the fact that their money. And if we just looked at out of these household contacts who actually had low well-being or ill-being, well, it was the contacts that had TB themselves. It was the females that scored lower. If you're an older contact, you were scored lower. So I was worried originally that that difference that we saw in TB caregivers is because we had more women and we had an older group. But when we, the figure that I showed before, we adjusted for those differences in demographic, and that lower well-being that you see in caregivers, it holds true, it holds true regardless of those demographic differences. And if somebody was a TB caregiver, and if they were caring for a patient that had many needs, many other needs, then the caregiver had less well-being, so more ill-being, lower scores. So in summary, and really the take-home message is that informal caregiving in TB is distinct, I think is a distinct group than caregiving in other settings. And also that caregivers from this study that we're showing feel more financial pressure and are generally less satisfied with their quality of life. So we talk about social protection and economic protection, and not only do they need to be protected, but they probably need to be supported as well. And so I just wanted to end on a picture of some of our community health workers actually helping this grandmother who was a carer of 3 people in her household that were going through TB, and unfortunately one passed away and in the setting where she lived, and to say thank you to every single study participant that helps us with the study, and our funders and our wonderful group who are in their little figure with all the masks in the background. So thank you very much for giving me time to share our experiences.
Thank you so much, Simona. Very compelling talk there, just highlighting the challenges that people face in low and middle income countries when embarking on the crucial tasks of caregiving. Also the issues of just how tuberculosis presents very special challenges when compared to other diseases. So really crucial information you're sharing. Thank you so much. We will come back to you maybe with some questions from the audience. I think what we can do now is to continue with our next speaker. So we are going to listen next to Joseph, and Joseph is going to talk about gendered perspective on caregiving from the South African context. And just a brief introduction about Joseph. Joseph Daniels is an associate professor in the Edson College of Nursing and Health Innovation. His research focuses on the development, implementation, and evaluation of social and behavioral interventions that will address health disparities and foster thriving individuals and communities. And for more about Joseph, I also refer you to the longer bios on our site. That's going to be after the webinar. So please go there and read more about our speakers. So over to you, Joseph.
Thank you, Jeremiah. It's a pleasure to be here, and thank everyone for being here with us. So I'd like to, build off of Jeremiah, Dorothy's, and Simona's talks. And like Jeremiah suggests, really sort of uncover or, examine sort of a gendered perspective in caregiving, looking at men and women caregivers, particularly in South Africa, which is where I'm at currently. We had different definitions of caregiving. Jeremiah really articulated that, it has different permutations. And, all of us, as Simona stated, we wear these caregiving hats throughout our lives in different roles and responsibilities. And so I'm interested in looking at particularly like immediate family members and their caregiving roles during TB illness and the treatment pathway. And also through a sort of a gendered perspective. We know that we need more caregivers. But we also know that there's caregiving practices ongoing. In the US, for example, there's about 16 million male caregivers for aging folks in the US. We don't really have a sense of sort of male caregivers sort of globally, particularly for TB and their roles. Also, we kind of don't know how men's caregiving is defined, described, or acknowledged. And this may be linked to sort of manhood norms around what it means to be a caregiver and those responsibilities. And this sort of identification, self-identification, or by community may ultimately sort of deter men's caregiving practices. My ongoing work here in the Eastern Cape of South Africa is in part developing interventions to sort of engage men more in sort of peer support and also caregiving. And so this is some of the data I'm going to talk about today. So a general overview, we're trying to understand men's and women's experiences with TB care and treatment, those factors influencing their treatment journey, acknowledging MICE funding. And through one of these studies, we asked men and women, could you, identify a sort of immediate caregiver, someone that, we could interview and talk with about their experience providing you care during your TB treatment and illness. And so we ended up with about 45 caregivers that we did interviews with, and 10 men and 35 women that we interviewed. And I should also note, this is presentations building upon a presentation that I did at the Union Conference last year. So I also, within the setting, here in the Eastern Cape, you'll see here that this is the sort of TB incidence in 2019. Very little has changed since then, and from the various ages. And you'll see here that men are in red and women are in yellow. And we see that there's double the incidence rates amongst men in this setting. So TB incidence remains quite high. So what we found with our study was that, we found that caregiving actually starts for both men and women, actually are practicing caregiving at the start of when they identify someone in their family that has symptoms. And this caregiving actually is grounded in a reciprocity. So, these are some quotes. He was feeling cold, constantly asked me to rub his back, and forgive me. And then I encouraged him to go to the clinic because he also suspected that he had TB, and this is a brother. Most of the men that we talked to, well, some, I say about 50%, had caregiving experience in the past, not necessarily with TB, but for other responsibilities, and the example above. And this is in particular demonstrated that this brother supported his brother because he was the person that raised him, and since they were young, so they were definitely have been supporting each other over their life course. And then the reciprocity is demonstrated here that both men and women discussed, how their support is situated in a history of mutual support. So here, because he assisted me in the house, I got a few things for him when he was sick with TB. For example, when he needed food, I didn't tell him to buy food. He eats the food that I buy. When he gets a job, at least when he gets well, he will say to me, "Aunt, here is money for vegetable. Here is money for meat, you see." And so there will be sort of an expected reciprocity for sharing of food during TB illness and treatment. I think it was demonstrated in Dorothy's presentation is that a lot of folks incorporate their personal stories and experiences into their caregiving, not only for motivating people to stay on treatment, but they also use it as points of identifying preemptively where someone might have trouble taking their treatment. So then they can preemptively anticipate this and then sort of guide them through this process. So in the sort of final quote about a mom to her son, I know that when you're ill, you lose appetite. So I always encourage him to take small portions of food. So, given her experience, she knows that, illness and treatment may influence the appetite. And so she can anticipate this and provide guidance through this process. Now, caregiving is not formalized here in South Africa. So there is not sort of a set of, caregiving guidelines or support. She is actually leveraging her own personal experience by herself to find a way to support family members through TB treatment. However, we do know, as we've all heard already, that caregiving presents a financial burden and risk to household and relationship. So we know that men and women caregivers do provide support and resources such as food, housing, and transportation to clinic. But these present strained moments on the household. So, in this case, when a mother is supporting her son, she says it was very difficult. And, I had to move money from crèche with his, daycare for my child in order to provide money to my son to complete treatment. And then another brother talked about his taxi breaking down. It was very difficult for him to gain money to support his brother. And so then he had to find himself in a place where he has to ask money from other men in their setting. And the asking for support and money for this presents particular challenges of indebtedness to those men, etc. But nonetheless, they needed the money to buy groceries. So in sum, caregiving practice is sort of influential on TB treatment outcomes, as we noted, but we also need to recognize this work and support this work. This research has shown that both men and women care for men and women in TB in different ways during TB treatment. So it is happening that men are actually doing this work. We also know that through our analysis that manhood norms may influence how men provide certain types of support and other types of support they may not provide. It may be that their support is less routine than compared to women. Women are more likely to report sort of financial risk to family and household as a result of caring for someone with TB. Men are less likely to do so. Also, amongst folks that don't have a support system prior to TB illness, these obviously presents particular gaps in this support system. And we are particularly looking at these folks, and we are working on sort of enhancing this intervention called a Coach and Pilo, which is a male-to-male peer navigation intervention that was developed here in South Africa for HIV, and we're tailoring it for men with TB for peer navigation for men that don't have this core support structure. But as Simona has also said, that we need to answer these questions. How do we maintain well-being of caregivers? So questions I'm very interested in, during the process of caregiving, if someone has TB history, does the process of this caregiving sort of generate recall of traumatic or stressful moments during their own caregiving? And how does this impact their caregiving practice and their well-being? And I'm also interested in sort of the more emotional support that they're providing and also the more tangible support beyond sort of grant systems. All my work, I want to say, is in close collaboration with Dr. Andrew Medina Marino at Desmond Tutu Health Foundation here in South Africa, and also my researchers and leadership. And these folks are my mentees, Zizi Polta, Kelly Rudd, Kruhe, and Lindsay and Dume. Also, we want to thank all the men and women that we interviewed for our studies, and also our close collaboration with the BCM and District of Health of Eastern Cape, South Africa. So thank you.
You, Joseph, thank you really. I think you brought in another angle that we struggle with, the issue of men and their health and well-being in the broader sense, and as part of societies and communities, as part of families that they support, with that they, seek to support and protect and play their roles therein. And you're just bringing out this important point that we need also to continue to look into how caregiving can be supported for this particular group, but also to improve the well-being of the whole family. So very, very important work, Joseph. Thank you. We'll get back to questions that may be for you, Joseph, later on. We'll now listen to Carlton. Carlton will talk to us about what have we learned about informal caregiving from other health issues. So Carlton Evans is a professor of global health who is leading what is called the IFAD, or Innovation for Health and Development Group, in the section of adult infectious disease, Department of Infectious Disease at Imperial College London in the UK, and has several other university connections, which you can also look at on his bio. And his research is focused on innovative strategies for improving health and development, especially for vulnerable people globally. Over to you, Carlton.
Thank you. Hello everyone. We're just trying to share our slides. I must say it's really inspiring and also humbling to follow such exciting and important presentations. Thank you. Really wonderful session, and I'd also like to thank and state my admiration for the organizers for giving emphasis to this very important and neglected area, and to Dr. Ernesto Amarillo from the World Health Organization, who for decades now, literally for decades, has really been leading, pioneering, and advocating very successfully a major force achieving this growing recent emphasis in TB, not just as an infectious disease that needs to be cured, but also as a socioeconomic issue for which we need to support affected people whilst also trying to remove their germs. So our work is really inspired by that leadership and also by the important examples that we can learn from the role of social protection in improving the outlook and the life of people affected by other conditions. We've worked for 25 years now in the shanty towns that constitute the northern extent of the mega city Lima, Callao, the capital of Peru, that you can see a photo of on the right hand side. Are you able to, maybe Joseph, you could show me the thumbs up if you're seeing my slides advancing? That's super. Thank you. And This is a very important graph that it shows along the horizontal axis TB-related costs. And like most economic measures, they don't work very well if we consider them in dollars or pounds, because of course a dollar or a pound to one person is very different to a dollar or a pound to a much wealthier or much poorer person. You can hear our wonderful children wanting to make their presence felt. So in all this type of work, costs are expressed as a proportion of that household's pre-illness income. So it's costs kind of related to how poor or wealthy that household is. And on the vertical axis, you can see for the dotted line, let's focus on the on this dotted line here, the likelihood of successfully completing TB treatment. And you can see that as the costs increase, the likelihood of completing, of being able to afford to complete the 6 or more months required for a good TB treatment outcome plummet down to almost nothing. And that's just one of many examples of the importance of catastrophic costs related to TB and the very important leadership of the World Health Organization in promoting and emphasizing catastrophic costs, preventing all catastrophic costs as one of their 3 headline targets for ending TB. Catastrophic costs defined as when those TB-related costs exceed a fifth of the pre-illness household income. But I'd just like to point out something else from this graph. Whilst on the one hand, emphasizing the importance of catastrophic costs as illustrated by this graph, I'd also like to just point out to you these little crosses and circles at the bottom, which show the adjusted and unadjusted, very similar measures of the population attributable fraction. And whilst at the same time emphasizing the importance of catastrophic costs, these suggest that if magically we were able to achieve the World Health Organization target overnight of ending catastrophic costs for TB, which would be wonderful and very important, that would only prevent around a fifth or a quarter of the adverse TB treatment outcomes. So the money's important, but it's not all about the money. And when I was diagnosed with TB, that was certainly my experience, that the economic effects were important, but the fear, stigma, marginalization, and depression associated with the diagnosis were even worse than the economic effects, despite the fact that, of course, I come from a much massively more privileged background than most people struggling with a TB diagnosis. And that's why you can see in the top yellow panel of this slide that we tend to work with integrated social as well as economic support. So economic support addressing catastrophic costs and enabling households, families affected by TB to successfully complete treatment and move towards cure is of immeasurable importance, and we believe that importance can be further increased by integrating it with social support. And that vision leads to an inevitable challenge that is central to this session today, because TB programs improve the exemplary model TB program. TB programs all over the world struggle to diagnose and treat everyone with TB. Globally, they're assessed to diagnose and cure only somewhat less than half of the TB in the world. That's the formal estimate. And even for the patients diagnosed, the proportion who are cured globally are alarming. So how can we add to that incredible work, that incredible challenge for TB programs, providing socioeconomic support, when their budgets are already overstretched and they're already struggling to address the principally biomedical goals that they have traditionally inherited? And for us, the answer appears to be informal caregivers, and specifically facilitating TB survivors, the peers and often family members of patients and patients who've survived TB, and their household members, their carers often, to become community health workers to support the TB program and its goals by supporting newly diagnosed people with TB. So integrated social and economic support, empowering equitable access to the biomedical and other care, biomedical and social care provided by TB programs. And you can see here 3 illustrations of the integrated socioeconomic support package that was led by informal caregivers, excuse me, as the intervention in this CRESIPT trial. On the left, you can see small group works led by a TB survivor addressing the stigma associated with TB, providing information and support to small groups of newly diagnosed members of TB-affected households, because not everyone is able or keen to engage in this sort of work. So also TB survivors, informal caregivers visiting patients with TB and the people living with them in their homes. And all of this integrated with dumb phone, cell phone, dumb phone, simple phone, cash transfers to try to economically support families affected by TB to be able to afford to complete the care recommended and provided in Peru for free by the excellent TB program. And here you can see the first of 2 results, which are tremendously exciting. And they're presented in a way which will be familiar to most of you. The black dotted line shows the control group. So this was a trial, just like a trial of medicines or vaccines, but in this case, a community cluster randomized trial comparing 16 communities where we didn't do anything, because you can't intervene everywhere in research, versus 16 other communities where we offered every household with a new TB diagnosis, this informal caregiver-led support. And on the left, you can see the proportion of patients with adverse outcomes. And so you can see that about 1 in 5 patients with recently diagnosed TB had an adverse treatment outcome over 18 months. So treatment failure, being lost to follow-up, called in Peru abandoned, inability to be able to complete treatment, death or early recurrence immediately after apparent cure. And you can see that was reduced by over a third, by 35%, bringing it down to the red line, in the communities where this CRESIPT integrated socioeconomic support package was offered. And on the right, you can see the other major outcome, that excitingly, this intervention didn't just help the patients, but it also helped the people living with the patients. You can see in the black line again that almost 3% of the people living with the patients in the control communities, the 16 control communities, were diagnosed with TB disease and started treatment for TB disease, and this was reduced by 43%, getting towards a half in the communities where this socioeconomic support package was offered. So very, very exciting and very important. And just two more quick results that I'd like to share with you, which seem particularly relevant to the theme of this seminar today. And the first is really very resonant with a point that Simona made in her excellent presentation, that being an informal caregiver is often seen and often found to be an, at times, unbearable challenge. And we were very struck by how working with people successfully completing their TB treatment to become informal caregiver peer mentors for other newly diagnosed patients with TB in their households, training and supporting them to do so, seemed to be tremendously inspiring for them. And many of them talked about it as being an almost dominant silver lining to the curse of having been diagnosed with TB. And that's supported, I won't go into the details of this slide in the interest of time, but that's supported by our quality of life questionnaires, which Simona described, which showed that indeed, in all the people in this project, the highest quality of life was reported by people trained up to and functioning as peer mentor, informal caregivers for other newly diagnosed households. So this was not so much a burden, but significantly here a blessing, an exciting opportunity for many of those people, which is very, very exciting. And then the last slide is perhaps the most important, because giving cash money to people with TB is very important and very desirable. But for TB programs that are struggling with their budgets to care for the people who are already diagnosed, finding the money to additionally give people diagnosed with TB and their households cash transfers can seem very challenging. And to my surprise, when we asked everyone emerging from this intervention to give their feedback, the feedback of how much they valued things was not particularly informative, because they were very positive. They said everything was great. So those scores were kind of just very high and not very informative. But when we asked people to rank what they found most helpful, what aspects of this integrated socioeconomic intervention they found most helpful, then the answers were very surprising. I would have imagined that in this impoverished setting, for people suffering from this impoverishing disease, that the cash transfers would have been what they rated most highly. And they did rate those cash transfers as enormously important and valuable to them. But they rated the peer support, the human, social aspect of the intervention, being paired up, teamed up with TB survivors and supported psychosocially by them throughout their treatment, both for patients on the left and for those patients' household contacts on the right. The social support in red was ranked very much more highly than the economic support. And that's not to belittle in any way the importance of the essential need for economic support. It's just to show evidence that we would be wise to integrate that money we're trying to give people affected by TB with peer, informal caregiver, social support also. And that's not just an isolated finding. This is my last slide. That's not just an isolated finding from this CRESIT trial on the right, our most recent trial, also in the HRESIT trial, which is fully published, and the ISEAT fully published previous trials. Also in those trials, the participants rated the social parts of the intervention even more highly than the economic support they received. So good evidence that we can increase our income impact, we can increase how much we're supporting TB affected people if we integrate social with economic support. Thank you very much. Bye.
Thank you, Carlton, for very interesting presentation, really just highlighting how this integrated social support intervention led to reduced adverse outcomes, but also even for the other members of the family. And I also noted the value that the people who had TB put to this role, and of course to your last point, the centrality, the importance of social support. In addition, of course, as you emphasized, to ensuring people affected and communities affected are also protected financially. All those are very interesting insights. Thank you so much. Thank you so much, Carlton. I'm going now to call upon the Ramya Ananta Krishnan. Ramya, I hope she's online. Yes, there you are. And okay, welcome, Ramya. So Ramya is
Jeremiah, you're muted.
I'm really sorry about that. Okay, just to thank Carlton. Thank you, Carlton. I thought I was unmuted. Really, my apologies. But I'm going to quickly call upon Ramya now. And Ramya Ananta Krishnan is going to talk to us about perspectives from TB implementation in India, people-centered TB care, empowering and supporting informal caregivers, including TB non-bans. So briefly to introduce Ramya, she's the director of a non-profit organization, REACH. She's a medical doctor with a master's degree in community medicine and has been working for close to the last 19 years in the field of tuberculosis. She's also the chair of TBPPM Learning Network India chapter and had several initiatives across the country. Again, I refer you to the bios attached to our website for this webinar. I'll ask you,
sorry, you got muted again.
Did you catch anything that I said earlier?
Yes, everything except the last line.
All right, and I'm not sure what's happening with my computer. I'm really sorry. So, but I'll just ask you to share your thoughts now with our audience. Over to you.
Thank you. Thank you very much. And good morning, good afternoon, good evening to everyone. I take immense pleasure in talking to all of you about caregivers, especially when we talk about person-centered, holistic care. Caregiving is such a critical component of this because just giving drugs and access to diagnostics is not enough. And I think the previous speakers have highlighted how important the role of caregivers are in ensuring that a person with TB receives psychosocial support while they are on treatment. And this psychosocial support is critical to encourage them to stay on track of treatment and complete treatment because they have many challenges related to stigma, related to livelihood, which would potentially prevent them from taking treatment regularly and completing treatment. So if I could just request Petra to share our slides, where I would just like to talk to you very briefly. I just have two slides. One is want to highlight based on the work that we have been doing in India. So we have this cadre of people that you see. They are called the TB Nanbans, friends. Nanban means friends, and they play a pivotal role in providing care and support to the patients who get diagnosed in the private sector in the initiative that we are currently implementing in India. So these TB Nanbans play a very important role in ensuring that a person who has symptoms of TB, who gets referred from a private practitioner, actually completes the diagnostic and care cascade. And these TB Nanbans are basically identified from the community. They don't have a very big a medical background or a health background. So they are either like graduates, or they have like 12 years of education, and they get trained to provide care and support to people with TB. And they literally become friends. They literally provide mentor and counsel people with TB. And especially if you look at private sector, where the doctors don't have time to interact with the patient, the person with TB derives a lot of counseling, gets a lot of emotional, psychosocial support from these TB Nanbans. And at the end of treatment, TB Nanbans literally become like their own family members. And many times we have instances where TB Nanbans say that they call them for their weddings or any happy occasions. They become part of their family. And I think that conveys the true power of providing care to a person with TB. So they are truly the caregivers, and they not only counsel the person with TB, but also the family, because many times because of stigma, they are separated from their spouses or from their families, and they play an important role in getting back into their own family. So in fact, they're just ordinary people doing some extraordinary work through their caregiving and support. And I wanted to highlight one such people who are the TB Nanbans. Next slide, please. Another group of people are the TB champions, who are basically the TB survivors who've been trained to provide peer support and caregiving to people with TB across the country. And as you can see, the various TB champions, just by the fact that they come out and provide support, they are able to break out of their own stigma. They become empowered. And they use their own personal journey to motivate another person with TB. And that has really found a huge mark in a person with TB, because they see their own neighbor, a person who is very much from their own community, getting cured and is able to lead on a good life. And by becoming a TB champion, they actually get a lot of standing no, they become go-to people in the community. So they see the growth of the TB champions and feel motivated that they could actually come out of this disease successfully. And the kind of care they provide, not only is it peer support and counseling, they also do house visits. They make sure the people with TB get access to the social welfare schemes that the program has. They help them in opening bank accounts, and as you can see, a person with disability, they make sure they get the disability pension scheme that is available. They make sure they get access to follow-up diagnosis, treatment. They also do vulnerability assessment, gender-based counseling. So they take on many, many roles and responsibilities, and provide that care and support for a person with TB. And I think these both the instances where we identify community people from their own community and train them to become TB champions or the TB nun-bins, it plays a very important role, because while health system is focused on clinical care, and usually like in countries like India, where the number of people with TB that clinical care provider needs to see on a daily basis is quite high. These people play a very, very critical role in ensuring and counseling and motivating a person with TB to complete treatment, to get that peer support, to come out of their own stigma, and to look at other social issues that that person has and link them to appropriate social welfare schemes. So I think this is something which can also be sustained as when we look at caregiving, because the previous presentation was talking about the various costs involved, and and I think as we find these community champions from within the communities, they're going to play an important role way forward in the TB care and prevention landscape. Thank you very much.
Ramya, thank you. Okay. All right, sorry. Thank you, Ramya, for sharing these insights. And I think what we are seeing there is really just how powerful a gap, a role as caregivers play in the community in terms of being a source of social support beyond the clinical support that can be offered from the point of the healthcare facility and the healthcare services. I'm now going to ask Ernesto to also share his reflections. Ernesto will speak on global policies, social protection frameworks, and gender, reflecting on how to engage, empower, and support informal caregivers. Ernesto Yaramillo is a Colombian medical doctor with a PhD in health education from the University of London. In his career, he has covered clinical, programmatic, and research issues in TB, and between 2006 and 2018, he was the TB drug resistance policy lead at the WHO, and since 2021, he is the lead in WHO for ethics, equity, human rights, social protection, and disability at the Global TB Program Department. Ernesto, will you share your thoughts? Over to you.
Thank you, Jeremiah. Would you mind to remind me how much time is left for my intervention, mindful of the
That's thank you, Ernesto. I think we have probably less than 5 minutes. I'm not sure how much further we
Good. Okay, I will convey my key messages within the time proposed. First of all, I would like to make echo of the remarks that Carlton had in his opening of his presentation, and to congratulate the conveners of this meeting, Petra and her team and colleagues, because definitively caregivers is one of those key players that are not getting the visibility and support that is necessary in the fight against tuberculosis. And what I would like to do within those 4 or 5 minutes is to share how we are having a political and policy context that the whole of the TB community need to harness more proactively and with more intensity, passion, and also with more strategic thinking. First of all, let me remind you all that one of the pillars of the NTV strategy that has been endorsed by member states is the people-centered integrated care. So the thing is that when we want to go deep inside what people-centered care means, questions like who are they that we want to cover? Is people, our patients, our families, and center around what, right? And what is the nature of the care we are talking about? And implicitly in these questions is the issue of who are those who are supposed to deliver care. Within the global approach to TB, there is the natural tendency to focus on the formal caregivers. However, when we look into what is the nature of the care, that includes that, but goes beyond the role of the healthcare givers that are within the health sector and includes members of the society and those who are close to the people suffering of TB. And what we are caring about, right? It's about relations. I'm presenting here one of the most widely accepted definition about the care we are talking about when we have the discourse of healthcare giving. Who are the people we are caring about? Well, in any society are the people who are more impoverished, the people who are found to be more vulnerable to the way the societies are structured. Because of that, then the nature of the caregiving is different to the caregiving for other members of the society and can explain the kind of challenges that some of you have presented in previous sessions during this webinar. And one element that is also then fundamental to discuss is what is the nature of the values, needs, and preferences that people with TB are expressing and how the caregivers are prepared to respond to that, to what extent they are also sharing some of these needs, some of these values, and some of these preferences, and to what extent we end up having very poor people helping also poor people to struggle, to deal with the daily struggles they are suffering, and how we are as a society and from the government and from these global agencies like WHO supporting those caregivers. So there are plenty of questions that have not yet fully explored and that are centered around this notion of how to ensure that the people with TB are at the center of the response. WHO over the years have presented a collection of different policies that are looking at fundamental elements of the caregiving because of the nature of tuberculosis requires a lot of interventions from the people affected with TB themselves. It's not only about what the government can do, but also about how people with TB can respond to the challenge of, for example, adhering to treatment. Adherence to treatment is a very complex behavior. And the old fashion of promoting direct observation of treatment has completely ignored the context in which adherence to treatment operates. Hence the importance to have a centered approach in which fundamental values and preferences are considered. And in that context, the guidelines of 2016-17 were having a very open approach, highlighting the need to focus on enabling adherence instead of forcing adherence, enabling adherence. And for that enabling of adherence, the role of the caregivers is fundamental. Health education, getting TB communities health literate, not only to understand about disease and its treatment, but also to understand the social nature of the disease and the responsibilities that governments have in the response to tuberculosis. Delivery of care is one of those contentious issues that again reflects how the role of caregivers could be positioned in a way that the preferences and values of the people with TB prevail above what the formal healthcare workers quite often demand. And finally, I would like to mention one of the major milestones in recent years, which is the full embracement of social protection as part of the response to tuberculosis. And here, just to finalize, I'd like to emphasize two elements that tends to be confused here. Social protection is a human right. And because of that, is the government the one who is responsible to ensure that everybody with tuberculosis receives social protection. It's not the responsibility of the communities. Quite often, it happens that in view of the lack of commitment from governments to protect the human right to social protection, is delegated into the communities that responsibility. And of course, communities and relatives and close caregivers can provide social support. It's in human nature. Solidarity is one of those values that the NTB strategy and the guidance on ethics is promoting. And solidarity applies to the caregivers who are in the community. And they are, by nature and quite often of necessity, providing social support. And we have provided some guidelines on how to ensure that social support can be delivered in an effective manner. But social protection is the responsibility of the governments. The United Nations General Assembly political declaration at the high-level meeting held in September made an incredible innovative commitment that had no precedence in the fight against tuberculosis. The heads of state pledged to ensure that everybody with tuberculosis receives social benefits, social protection to eliminate the financial hardship. So civil society has to demand governments to remain to that pledge, accountable to that pledge, and effectively honor that commitment. That should not compete with social support that in parallel can be delivered and promoted by the informal caregivers. In short, my call here is to prevent that by delivering social support through the community, the responsibility of the government is washed off. And then we have a human right unprotected and perpetuating this situation in which tuberculosis is getting less visibility, less funding, despite affecting the most vulnerable people in every society. I would like to stop here because obviously time is short, but again, I would like to congratulate you all for your interest in this area and renew the commitment of WHO and this department to support the work you are all doing. Thank you.
Ernesto, thank you so much, and thank you for that clarity and emphasis on who should be responsible for social protection. I think that message was very clear and loud. I see that the panelists were responding to some of the questions already as we were going. So, Petra, should we do we have time for a few questions, or should we round it off?
We are already 5 minutes over time.
Yes.
And that's just because this topic is so important, and all the wonderful panelists had fantastic presentations, and each of you spoke so passionately about your work. Clearly, I mean, looking at the amount of participants for a month when it is a summer period, I'm glad to see so many of you with such excellent questions and engagement. I really would like to thank everyone very much for your thoughtful presentations, wonderful research work. Please keep it going. Dorothy and Ramya, for your on-the-ground concrete work that you do in Chennai and in Kenya. Fantastic examples, and thank you for sharing. And Ernesto, your powerful closing words, I'm not even going to try to summarize because you hit the hammer on the nail with some of the key components, so really appreciate it. Joseph, you were the one who brought us all together. Thank you for inspiring everyone to bring this important topic of caregivers really to the center of everyone's attention. And I do feel that it is an opportunity to maybe, I'm not looking at opportunities to see how we can highlight this, the role of caregivers more, whether that is through highlighting your research or doing maybe a forum discussion, bringing more caregivers together. Dorothy, maybe some of your colleagues, and Ramia, some of your colleagues, where we can have some of the practical lessons being shared. And so I really want to thank you all for your thoughts and your input. Want to wish everyone a wonderful rest of the day, and know that we will be putting everything out there to make sure that this topic gets highlighted, and hope to bring you all back together. Jeremiah, fantastic job on keeping us all on track. Thank you so much. And with that, I would like to close today's webinar, and wishing everyone a fabulous rest of the day. Thank you so much. Goodbye, everyone. Really appreciate it.
Goodbye and thank you.
Thank you so much.
Thanks, Petra. Great.
Thanks, Joseph.
Great job. Thank you. It was fun. Talk to you later.
Talk to you later. Bye.